Welcome back, everybody. Today we're going to talk about sleep lab scheduling. Sleep lab's nothing without patients, and patients don't go anywhere unless they've been scheduled. Sleep lab scheduling is a tremendous job, and it really only needs to be done by competent individuals who understand the sleep study process. Poor scheduling and organization can hurt a lab's reputation, but it can also hurt patients by delaying their care. There are several types of sleep studies, and it takes a skilled scheduler to know the difference between each one and also when to schedule them. Sometimes lead technologists are required to do more complicated titrations or full head hookups because of their expertise. Uh, PSGs are just the run-of-the-mill regular hookups, looking for diagnostic stuff like sleep apnea. Parasomnia montages add extra EEG and sometimes even EMG wires. PAP titrations require additional equipment and sometimes additional expertise there too. Split nights are nights that are scheduled to be half diagnostic and half titration, so the physician actually schedules it that way instead of it just being on the fly. MSLT means multiple sleep latency tests. These studies require a previous night study and then the daytime MSLT study. So that's going to be tackled by two different technologists. You're not gonna have one technologist running 36 hours most likely. Uh, MWTs, maintenance of wakefulness test. Those are also performed during the day. Pre-MSLT studies might also need to be run by a lead technologist because they have to score the study on the fly to make sure the patient qualifies for the daytime study. Nocturnal seizure in PSGs require a full head EEG hookup, so you got to know how to put all the wires on and in the right place. Basic nocturnal polysomnograms are the bare minimum for the in-lab sleep studies. They are for diagnostic reasons, like to check for sleep apnea, restless legs, periodic limb movements, poor sleep quality, insomnia, stuff like that. They're usually performed in the evening during the patient's normal sleep time. Sometimes there are accommodations for those who work the third shift, either if patients keep odd hours or for pediatrics. Usually they start earlier and finish later. Parasomnia montages are similar to NPSGs, but they add a couple more EEG wires to detect waves from more locations. Sometimes additional EMG wires on the arms. Recording is necessary for every sleep study, video recording that is, but most definitely for parasomnia montages. These are for night terrors, REM behavior disorders, somnambulism, and other parasomnias. This is usually the montage used for a pre-MSLT study. PAP titrations, and when I say PAP titrations, I'm talking about any kind of therapy that's got the mask and pressure. PAP can mean CPAP bilevel, auto PAP, ASV, all those are PAP titrations. And they're all performed under the same conditions as NPSGs, but instead of the thermistor and the nasal pressure cannula, they just wear the CPAP mask. And the CPAP in the lab has the ability to link up to your computer software and display the CPAP data in real time. It'll show you the set pressure, what the machine is actually delivering, the humidity factor, and the leak value. These are also performed after a diagnosis is made and usually runs about the same amount of time that NPSGs run. You might hear this as a second night study, even though it's not really on the second night unless the lab has nothing to do and that patient doesn't either. Sometimes these studies need to be run for more time if you have to split the night between PAP modes. For instance, if you start a patient on CPAP for their OSA and then, they have complex sleep apnea, which means sometimes patients on CPAP can start having central activity. Then you have to have enough time to prove that they need something else, and then have enough time to do that something else. And according to you have to follow the PNP of your specific lab because some labs will be, you know, after this many events, switch over, or after 3 hours, switch over. So you want to have enough time to make sure the patient is fixed also in every position in every sleep stage. Sometimes patients are obviously so sick with sleep apnea that it's feasible to complete a diagnostic in the first half of the night and then try treatment for the second half, and we call that a split night. There must be at least 2 hours of total sleep time before the 3 hours of total recording time, and it must have at least 3 hours of recording time for the treatment period. These are recommended by the AASM. Different labs have different protocols. Some might ask for more time, some might ask for less. Occasionally, split nights are scheduled if the patient doesn't have the funds for two studies, or if a patient has been identified as high risk for sleep apnea, it can save them time and money. There are also times where something called a reverse split is called or used. A reverse split night starts with CPAP, who has already been on CPAP, a patient who's already been on CPAP but needs a new prescription or new equipment. You can start the night with CPAP, and then once you've got them fixed and you've got enough time, then you move to the diagnostic study for the rest of the night. And the logic behind this study is that when a person has sleep apnea, their soft tissues in their throat, like their tonsils and everything back there, can become inflamed, making the obstruction worse. And sometimes that makes, you think you need more pressure. But if you start with CPAP, the patient is allowed to sleep without that inflammation on CPAP, allowing a more accurate titration to happen. MSLTs are performed after a pre-MSLT in PSG that reveals if the patient has sleep apnea or another sleep-related disorder that might stop them from getting a good night's sleep. And sometimes OSA can have the signs of narcolepsy. And the NPSG before make sure that they don't have a reason to be this sleepy other than narcolepsy. We would see that in the NPSG. They've got to be able to sleep for 6 hours at least, um, not have so many leg movements. I think it depends on the lab protocol, but you typically have to have an AHI below 15. Um, it depends on what your lab wants to do. Lately, MSLTs have been performed also not just for narcolepsy, but for idiopathic hypersomnia. And one of the main differences when doing these two diagnoses is it's usually about how many SOREMs are needed. The idiopathic hypersomnia patient doesn't really need a SOREM, they need to just fall asleep quickly and stay asleep. MSLTs start somewhere between 90 and 180 minutes after the pre-MSLT NPSG is over, or after they just wake up. There are 5 nap opportunities that they can, and it's every 2 hours. If the patient falls asleep within 20 minutes after lights out of the nap, the study is run for an additional 15 minutes after that epoch of sleep onset. If the patient doesn't fall asleep after the 20 minutes, that nap is terminated. When the nap is over, questions are asked like, did you fall asleep and do you remember dreaming? Although it's subjective, these questions may indicate the patient's sleep state perception. How accurate are they able to feel if they have been asleep or not? Every nap is separated by 2 hours. Before each nap, the impedances are recorded and some biocalibrations are performed. These are the standard MSLT rules. MSLTs are trying to determine if a patient can fall asleep quickly and start dreaming within the 15 minutes of sleep onset. These instances are called sleep onset REM periods, or like I've said earlier, SOREMs, and they're a big symptom of narcolepsy. Narcolepsy is literally REM, your dreaming state, interrupting a person's life either while they're awake or asleep. If you know anything about REM, you know that your body is paralyzed when you're dreaming. This is why the classic image of narcolepsy is patients falling down and falling asleep out of nowhere. That's not real for all narcoleptics, but this does occur in patients with cataplexy or the sudden loss of muscle tone. And that's a real thing. If you've ever seen the fainting goats on YouTube or online, that's the same kind of mechanism. It's right there with the fight or flight response. And something that is suddenly so funny or scary or elicits the fight or flight or freeze response. And due to that malfunction in the brain, the body goes limp and boom, they're dreaming. Uh, this is obviously a crucial study to schedule correctly. You need at least two technologists, one at night that's capable of recording the study or scoring the study on the fly, unless someone else comes in first thing in the morning and scores it, but that can cause issues if you have more than one MSLT. And that usually is the issue because you have maybe 1 or 2 days of MSLTs. You don't do a bunch of them, so you might not want the daytime technologist to come in and all the time. That can cost a lot of cash. So the daytime nap technologist must be passed off on scoring in the lab because they have to determine if the patient falls asleep during the naps. The length of the naps depend on it. Uh, the patient also needs to be aware of the time commitment this has. I mean, it's a full day, and right up to the evening again. Also, if the patient is not narcoleptic, sleeping in the lab overnight and then trying to take naps every 2 hours is not sleep hygienic at all. It's really bad for you, and it's going to be difficult for them to sleep that night at home. The Maintenance of Wakefulness Test, or MWT, indicates how well a patient can stay awake. The AASM recommended MWT guidelines call for the test to begin between 90 and 180 minutes after the patient wakes from nighttime sleep. Every 2 hours, the patient will sit in a chair in a dark room, uh, somewhere between 20 and 40 minutes at a time for 4 sessions. This has changed a lot. I've heard two 40-minute sessions and I've heard four 20-minute sessions. So it depends on the latest recommendations and what the physician is looking for. These are sometimes used for transportation workers, like truck drivers who drive at night, who spend their time in a darkened environment for hours on end, not really doing anything but looking ahead of them and driving. There's a specific uh, brightness in the room that's allowed for this test. Uh, this attention to detail is necessary because the environment should reflect a place that doesn't influence the patient to stay awake. There can't be any sound. The patient can't talk, they can't hum, they can't fidget or anything. They just sit there and they stay awake. Nothing else. They look forward. There are a lot of variances between these procedures, like I said, so you just have to be sure to stay on top of the procedures for your specific lab. This is directly from the website that I was talking about in the earlier slide, that you can find all this information about every study that you need to do, and this is talking about how much light has to be in the room. Sleep studies should be dimly lit, quiet, and at a comfortable temperature during testing. The light source should deliver an illuminance of 0.1 to 0.13 lux. And you actually need to measure that. There is a machine. I don't want to call it a luxometer, but I'm tempted to say that's what it is. But it's a machine that reads light, how much it is, how much light is coming from somewhere. And you can use that and put it right next to the patient's head if you have to, and that'll tell you if you've got the right things going on. There are other considerations that schedulers need to consider when assigning times to patients. They need to make sure that there is a chronological order to the appointment, starting with the initial consultation, then any testing needed, and then a follow-up appointment or appointments in the future. Some labs have patients just try to take a nap with a CPAP as a desensitization measure. PEP naps. Some labs will also provide a desensitization tour, especially for pediatric patients to help set their mind at ease about the sleep study. You can take them in and you can show them the paste. You can let them make a mark on you with your pencil on your hand or something, and you can scrub on the back of their hand with a little bit of prep gel just to show them that it's not going to hurt or anything, and that you got tape. And you can show them the rooms. Uh, there are also sometimes ad lib studies that's the first this is the first time I've heard of an ad lib study, but that just means they're going to go whenever the patient wants to go. If it's 2 hours or 12 hours, if the patient's able to sleep that long, that will give the doctor a lot of time to think about what's going on for the patient. Schedulers have to juggle all kinds of schedules to make one master schedule that the sleep lab operates under. They need to make sure that the right staff is working for the right kind of study when the correct tech to staff ratio. Let's say that again. They need to make sure the right staff is working for the right kind of study with the correct tech to staff ratio. It should match the patient's sleep schedule. If they are shift workers, advanced or delayed sleep phase patients, something like that, scheduling the right kind of study so that all the equipment is available for use. One time I had to run an Inspire study. That's where you've got the patient where they can, it's a sensor in their tongue and it'll jet their tongue out of their mouth so that it clears their airway every time they breathe. And I had a patient that was scheduled for an Inspire study, and she was scheduled before we even had the tablet to program these things. And she came all the way to Raleigh from Wilmington and had to go back home because we didn't have the equipment. She was really upset with me. I've never had a patient be so upset, but what are you going to do? Some patients are considered high maintenance, meaning they're either mentally difficult to deal with because they're oppositional to treatment or testing and they just don't, but they have to be there. Or they may require a lot of attention with titration if they're disabled, if they're pediatric cases, complicated health problems, or if they have severe anxiety. The sleep lab is almost always closed on holidays. It would have to be a super interesting case to do that. Schedulers also may be responsible for scheduling who the on-call physician is and pre-visit preparatory visits like a desensitization tour. Schedulers should understand the process of the sleep study, including how long the turnover is from acquiring the study, staging and storing the study, charting the report, the physician interpreting the study and writing up a report to getting the patient back for the follow-up appointment. Typically, labs are usually ready with the results for a patient follow-up around 2 weeks unless the lab is really backed up or if they just don't have any business. Schedulers need to know how long patients should be on treatment, either PAP therapy or sleep medication, before having them return to a follow-up appointment to consider continuation or discontinuation. Like you might have a 3 month PAP trial and then you come back and assess again, see how things are working. You don't want to come back after a week after it really hasn't had a chance to take a hold. For patients having an MSLT, it's important for them to abstain from certain medications for a while. Certain antidepressants that are known for being REM suppressants. When REM suppressants are used, REM is delayed until the very end of the sleep period. You won't see REM until it's almost time to get up. If this influence continues after the MPSG is over, the REM could show up during the naps, giving a false sleep onset REM period and rendering the study results inaccurate and unacceptable for a real diagnosis. The health of patients should also be considered. Sleep labs have exclusion lists for a reason. If the patient is not healthy enough to be in the sleep lab, they should probably be in a hospital. They may be able to direct such patients to these facilities, even schedulers can. If patients are unable to get into bed because of physical limitations, some labs are equipped with Hoyer lifts that technologists can be trained on to assist the patient into bed. Some sleep labs also have patients who have a more open schedule than other patients and can be put on the waiting list to get a quicker appointment in case another patient's cancel. Priority cases are going to be strictly up to the lab and the director and the protocols of the sleep program. But some labs probably have a hierarchy of patients that get next available study as soon as possible for different reasons. Maybe they are DMV employees, transportation workers, and people who fall asleep at inappropriate times. They all fall in potentially fatal positions if their sleep is poor. Patients who are losing their health insurance also might try to get earlier appointments to get care before they're no longer covered. Bariatric patients depend on a tight schedule for everything they have to do in order to get their surgery. Some patients with severe consequential sleep apnea, either obstructive or central, may also be assigned an earlier study. Typically, any situation where health and well being of the patient and others is compromised can be considered for an earlier time. However, aren't most patients who drive or work in a position to cause harm to themselves and others, if they don't sleep well? Again, it really depends on if it's a private lab or a hospital run lab and their protocols. In the presence of certain funny things that you might see or abnormalities that you see in the sleep studies, you should know when to alert the physician when these instances arise. For instance, any study with interesting cardiac arrhythmias, EKG, or abnormal EEGs, they're all good reasons to get the study scored quickly so that decisions can be made in a timely manner in case an emergency arises. If a patient is coming in for a follow-up, you need the study to be done before the patient comes back to talk to the results. The split night studies may also be considered a study to score quickly because therapy was preempted before a titration night, for example, and it needs to be expedited so that it can be approved by the insurance. Everyone who works in a sleep lab is under the supervision of a provider who is licensed in the state they work for. Period. Everybody is. They serve as the medical director on charge for all aspects of testing and patient safety. Since 2009, at least one accredited sleep technologist has to be on staff full time, or at least that individual has to be available to take the exam. So that's something else that has to happen through the scheduler. The AASM has rules regarding how many patients one technologist can run, and really they're just recommendations because people run four patients sometimes. If the patients are scheduled for a night and are not priority or have special needs, technologists usually are expected to run 2 studies a night. Some one-on-one situations would include pediatrics under the age of 6, severe health problem patients, hopefully not so severe that you have to really worry about their life, or difficult PAP titrations in patients with high anxiety that need some more help or accommodation. This is a good lab of what scheduling looks like for technologists in the sleep lab. There are 2 schemes, 2 shifts and 3 shifts. This is 3 shifts. In this scheme, there are 3 shifts that are available to accommodate people's schedules because of the abundance of technologists working. Here, daytime technologists score the studies, run daytime studies, MSLTs, MWTs, patient follow-ups, DME, and administrative duties, and HSATs. The second and third shifts are basically the same. It just depends on if they're going to start the studies or finish them. Maybe the daytime tech has someone that they started and the second shift's going to wake them up, and maybe the second shift has some studies that they're going to put down that the third shift's going to wake up. The issue with this whole scenario is cost of having so many technologists on staff in one day, but more patients are accommodated with this kind of staffing and it might bring in more business. On the other hand, you've got two shifts. Daytime technologists do the same thing. They might hook up patients, they might get patients up and take stuff off. And then there are just the third shift workers who work 3 nights a week for about 12 hours. For the three shifts, it's generally 4 10s. And 12 hours is enough to do all the things about a sleep study without having to hand it off to another technologist unless it's an MSLT, which are generally always handed off. This gets the job done at a lower price, but the patients usually have to follow the lab's operating hours over their own sleeping preferences sometimes. When talking to the patient about the schedule, if you ever have to do this yourself, these are some guidelines that you can follow. When talking to the patient about the schedule, introduce yourself and explain why you're calling. It's important to answer any questions that the patient might have about the sleep study. When contacting the patient, keep in mind HIPAA requirements. Some patients don't want information over the phone or in the mail. There should be options to be able to call for the patient at work or at home or on their cell phone. What times can we call, and who can we and who can we not leave a message with? This is usually all done already in HIPAA requirements at the beginning when they had their initial consultation. Explain which procedure they're having or which one they're scheduled for, and what to expect afterwards, including what to bring. Make sure the patient understands what you've said and what is coming in the near future. Reiterate the dates and times for the appointment. Make sure you have the correct contact information so you can reach back out if you need to. You should also make sure all the patient's information is correct after you make sure you have it all. The patient needs to know what they need to do if they cancel the appointment. Sometimes they have to pay penalties for not showing up, and I'm sure they want to avoid that. You should always document the contact you have with the patient, even over the phone. Document it and put it in their chart. Document how the conversation went and anything they were concerned about and how you followed up with that. A lot of labs send out mail with more information about the sleep lab. Uh, this is a good time to in the process to make that happen. You want to preemptively get insurance information so everyone knows what is expected of them when the study comes. Also, give the patient a call the day before the appointment to confirm that they are still planning on attending. Mail outs are good ways to inform patients about the sleep lab. It's something they can physically have and they can put it on the refrigerator and they can look at it because people can forget what's told to them vocally, but they can always go back to the paper. Things to have in the mail out include the lab address, how to get there through a map and directions, list the appointment date, time, and a summary of what the test will be like. It should talk about commonly asked questions like, can I still go to the bathroom? Can I read? What if I can't sleep? Can you see what my dreams are? No. In fact, Raleigh Neurology always says that we can see when you dream, but we can't see what you dream. You wouldn't believe how many people ask that. Things to not bring, things to bring. Always bring your medication, bring your pillow. Other morning or night times needs alcohol. If someone is used to going to bed with alcohol, they should bring it because that totally affects the sleep study. It can cause sleep apnea to be worse. So, if they're going to do it at home, they need to come and do it in the sleep lab too. If they're really serious about getting better. Things not to bring: work, things that cause stress, caffeine, inappropriate nighttime attire. Lots of men and women like to be fancy in the sleep lab, and it's just not the time to do it. Yeah. Okay, that's it for scheduling. A lot of this stuff is kind of dry, but uh, stick with it because the fun stuff is coming. The fun stuff is the actual sleep stuff. But all this stuff is important to go along with it because in the process, you're going to have your hand in a lot of it. So it's good to know how things work so that you know your expectations and what other expectations are for everybody else. All right, until next time, we'll see you.